Welcome and thank you for your interest in the RAPID program and the Patient Experience Partners, or PX Partners. My name is Scott Gorman, and I'm a program manager here in ARPA-H's Proactive Health Office, where my portfolio mainly focuses on the intersection of rare diseases and emerging technologies. And I'm the manager for our new program, RAPID, or Rare Disease AI ML for Precision Integrated Diagnostics. So a few notes about today's agenda. So this presentation will focus on key program information and how to apply to become a patient experience partner. We'll first provide an overview of ARPA-H and our Proactive Health Office, or PHO. I'll then describe the RAPID program. And next we'll talk more about PX partners and their essential function within the RAPID program. And also explain both the selection and the management of PX partners, and also highlight opportunities for patient advocacy groups to participate in the RAPID program more broadly. And we'll then wrap up the information session by describing the application process to become a PX partner, as well as answer a selection of frequently asked questions. If you have additional questions, we do encourage you to submit them through our program portal, and that's accessible through the top QR code on the right-hand side of this slide. And you can also use the bottom QR code to access our program page, where we'll share program updates, current deadlines, and application materials. And now to kick things off and tell you more about ARPA-H and our Proactive Health Office is Wade Shun, Director of PHO.
Before we dig into the details of this particular program, I thought it would be useful for you to understand the context of ARPA-H, this agency, ARPA-H, and how it operates. The mission of ARPA-H as an agency is to demonstrate and accelerate new capabilities that could improve healthcare outcomes for everyone. To do that, we run short-term research and development programs that focus on developing new capabilities and demonstrating that it's possible to make use of these capabilities in real-world settings. Programs begin by harvesting nascent opportunities that are emerging from early research and innovation, and they solve for a number of real-world implementation problems and scaling issues that then make it possible to develop a prototype that's deployable into the real world. And through the deployment and evaluation of those deployments, programs are then able to create the evidence that drives adoption of new capabilities and their implementations and into the healthcare system. Programs like this start from the early design phase, where we try to identify at ARPA-H core opportunities that are emerging from basic research that could potentially solve hard but well-defined problems in healthcare. We try to identify key technical challenges that need to be solved for during the course of a program, and then design an execution plan that allows for us to manage the technical and research risks associated with the hard problems that we try to solve during the course of these programs. We then work with the community to assemble a team of performers like you through these Proposers Day events that bring together the best of both industry and academic partners to build coalitions and teams that can then work on our programs over the course of the next 3 to 5 years to then execute our view of the work that needs to be done. Now, often the work during a program will change as we learn new things, as we discover that it's potentially possible to solve certain problems in a particular way. but maybe not exactly the way that we started off with during the course of our original program design, and we adapt. We often will accelerate work that seems to be promising during the course of a program, or cancel work that seems to be not as promising as we had originally hoped at the beginning of the program. Once programs reach a point of being able to demonstrate meaningful, viable capability in the world, we then will often work with performers, teams like you, to accelerate and transition and commercialize these efforts into downstream investment and or productization. The work of ARPA-H is divided up into 4 core mission offices, each with a different focus area in the healthcare system, and an office called Patio that is designed to take programs from the other mission offices and accelerate their transition into the real world through upfront support in the design process of programs and downstream support at the end of programs when technical results need to be facilitated and transferred to a wider community for adoption. The mission offices have different focus areas. The first of our mission offices, the Health Science Futures Office, develops very early capabilities through early research by expanding what's possible and by accelerating early research outcomes into very nascent demonstrations of new capabilities. The Scalable Solutions Office, on the other hand, tries to take later stage work that's happening in the other offices and in other research and accelerate the scalability of these solutions and their deployability into the real world by solving cost and manufacturing related issues that make it possible for solutions to reach a wider audience. Our office, the Proactive Health Office, is focused on new capabilities that prevent people from getting sick in the first place. That could be new capabilities that improve prevention. That could be new capabilities that help us detect and characterize disease and disease risk much earlier. And that can also be new capabilities to help individuals in our society adopt practices that prevent them from getting sick in the first place. And finally, the Resilient Systems Office focuses on building healthcare systems as a whole that are less than brittle, especially in the presence of crises like pandemics and social disruption. My office, the Proactive Health Office, is all about trying to reframe the work that we do in our national healthcare system around proactivity as opposed to reactivity. And the reason we care about this is that a lot of our national investment today, in fact, the vast majority of our national investment today in healthcare and healthcare R&D is spent on how to treat patients and how to do that better. And that's a worthy cause, but a significant portion of our health problems are actually in the space of preventable disease. So when we look at, for instance, cardiovascular disease that accounts for 1 in 3 deaths in the United States, about 80% of those cases are preventable with early intervention. Similarly, 1 in 3 Americans are at risk of developing diabetes and the complications associated with diabetes, but more than 90% of cases are preventable or controllable with early interventions. And finally, when we look at problems like mental illness, for which 1 in 2 Americans suffer from some form of this during the course of their lifetimes, probably 30 to 40% of those cases are preventable also with early intervention. And finally, even problems like cancer, which we traditionally think of as being something that we treat in medical cases, more than 45% of those cases are preventable or controllable with some kind of early intervention. Now, what that means is that if we were able to put a concerted effort on proactive health, a significant fraction of Americans and people across the world wouldn't necessarily need the healthcare system to solve problems that are entirely preventable in the first place. And the opportunity for us as a nation is to avoid maybe a third of annual deaths per year and potentially add 20 years of lifespan to the lives of Americans in terms of their healthy living. So I mentioned that the Proactive Health Office has a core mission to prevent, detect, and mitigate the effects of disease and aging. Well, to do that, we think that we need to develop a national capability to prevent people from becoming patients. And that fundamentally for us involves creating new ways to prevent, detect, and mitigate disease, facilitating the adoption of proactive care and prevention, and finally, we think it's going to be necessary to revolutionize the systems that could potentially enable access to and facilitate prevention and early detection within our society. Now, we think that there are really core opportunity. There are really a large number of core opportunities that could help us enable these objectives. These come in the form of bioengineering advances. They come in the form of better understanding of the biology of disease progression and better capability in AI and statistics for us to longitudinally and predictively model disease. And finally, we know that there are emerging capabilities in social science and the science of individual behaviors that could potentially be harvested to help us create new facilities for adoption of proactive care and could help us to create new systems by which we could facilitate the use of that care. Programs within PHO make use of these core innovation opportunities in order to be able to demonstrate and develop new capabilities in prevention, in early detection, and in the delay and mitigation of disease. Now, often it takes multiple different kinds of opportunities and multiple different areas of research for programs to be successful. In other words, our programs are often multidisciplinary in nature. So when we think about programs like RAPID that are in our current program set that you can see publicly online, these programs make use of capabilities like longitudinal data modeling and AI capabilities that are emerging to be able to make predictions about diseases, to be able to do things like potentially diagnose disease earlier or predict the outcomes associated with aging and aging-related prevention and wellness interventions. They also make use of underlying understanding of system biology and potentially advances that are emerging from biochemical engineering. And when we look at across all of our potential portfolio of programs, many of these programs are not just multidisciplinary in nature, but potentially end up solving a wide range of problems in order to demonstrate new capabilities that could transform proactivity in our healthcare system. Now, I'm not going to brief the details of some of our potential work, but what you're seeing here in blue are potential new areas in which we might develop programs in PHO. So keep your eyes peeled as to new opportunities that may be emerging from this particular office. For the purpose of the rest of the brief, though, know that your advances, the work that you are engaged in, represent core opportunities for this program to succeed and for future programs within PHO to be able to succeed too. So hopefully you'll be able to participate within this particular program as it moves forward. But even if you aren't able to do so, there will be new and interesting opportunities, we suspect, for some of the work that you're doing to become part of the ARPA-H family of research and outcomes. So join us in those opportunities as they come down the pike. Thanks again, and I'll turn it back over to the program manager to give you more details as to how this program will operate.
I'll now provide an overview of the RAPID program and then cover some of the most frequently asked questions. So there's a lot to cover, and I'll move quickly through the slides. But note that this deck will be available for download on the RAPID program page at arpa-h.gov. So every ARPA-H program begins with a what-if statement. This is our moonshot, a vision of the future that we're aiming to make a reality. And so the goal of RAPID is to accelerate the diagnosis of rare diseases and end what's called the diagnostic odyssey for the millions of Americans, and by some estimates, up to 200 million people worldwide who are living with an undiagnosed rare disease, and then efficiently direct them to the appropriate resource, which could be a treatment, trial, or patient group. So for context, there's more than 10,000 rare diseases, and when viewed collectively, they're actually far from rare, affecting 1 in 10 Americans and as many as 400 million people worldwide. And it's estimated that up to half of all people with a rare disease may remain undiagnosed. And these individuals face unnecessary or inappropriate tests and procedures, rising medical costs, and worse health outcomes. And on average, the journey to an accurate diagnosis takes more than 6 years and costs over $220,000. And yet, despite the enormous burden on individuals and the health system, there's been virtually no improvement in the average diagnostic delay over the last 4 decades. Today, the average patient journey extends for years and involves 7 physicians, 17 clinical interventions, and 3 misdiagnoses before an accurate diagnosis is finally achieved. And in many cases, patients can search for decades without receiving a definitive diagnosis. So the focus of RAPID is to proactively find individuals with undiagnosed rare diseases and end their diagnostic odysseys. And we aim to do this through the development of comprehensive and highly accurate AI-based diagnostic support systems to enable early and especially scalable rare disease detection. And current diagnostic models and systems face a number of limitations. Most lack comprehensive coverage of rare diseases, often focusing on a single disease or category of disease, while others that do have broader coverage can suffer from low precision and sensitivity, aren't fully integrated into clinical workflows, or are used late in the diagnostic process, if at all. And a key factor behind these challenges is that the data that's needed for training and validation is fragmented and siloed across many different sources. So RAPID aims to significantly improve model performance and rare disease coverage, as well as the deployment and real-world validation of diagnostic systems to ensure that they're effective and scalable. And RAPID will focus initially on more prevalent diseases, but then also expand to include ultra-rare conditions. And so essentially RAPID aims to build the foundation for a universal rare disease diagnostic support system, validate that using real-world data, and deploy across diverse settings, both in and outside the clinic, supporting diagnosis at multiple points along the patient journey. And this is an overview of RAPID's technical areas. So starting with TA1, we'll aggregate existing rare disease data to develop a comprehensive data set of longitudinal patient data that can be used for the training and validation of advanced detection algorithms. TA2 will then enhance that data by collecting additional multimodal data directly from patients. And the data from TA1 and 2 will then be utilized by the TA3 performer to create the largest database of curated rare disease data that's optimized for machine learning and includes also development of a rare disease data set that can be used for model benchmarking. And then TA4 performers will leverage the data and the platform to develop novel detection systems for deployment across both clinical and also non-clinical settings to validate and de-risk solutions for market adoption and scaling. But we're unlikely to succeed if we're not also integrating patient perspectives into each aspect of the program. And so to enable this, we'll select and fund a number of patient advocacy groups to create what we're calling a patient experience partner network. And so each performer team will collaborate with the PX partners who will provide user-centered design expertise across all phases of data collection, patient recruitment, and system development. And so RAPID is a 4.5-year, two-phase program. And in phase 1, TAs 1 and 2 will kick off the data collection, and TA 3 will establish the infrastructure, including version 1 of the data set used for benchmarking. At the end of the first year, once the baseline data has been aggregated, curated, and de-identified, we'll launch an open competition to test different approaches to detection modeling. And we'll then use the results from the benchmarking competition as part of the evaluation for selecting the phase 2 performers. And in phase 2, the TA4 performers will continue to leverage the aggregated data to develop rare disease detection models and the wraparound systems that are needed for successful deployment and validation in real-world settings. And throughout phase 2, the data collection and the data processing work will continue, so TAs 1 through 4 will all be running in parallel during phase 2. But the current focus is on phase 1, and teams are invited to now apply for TA1, TA2, and TA3. Teams can apply to multiple technical areas, or TAs, but each TA does require a separate proposal with a separate budget. And this is really to enable us to more efficiently select proposals and then expedite the contract negotiations. But if you do choose to apply to multiple TAs, please be sure to note that at the top of each proposal so that we can review them together. And a second solicitation specifically for TA4 will be issued in 2026, roughly concurrent with the benchmarking competition. And before moving into the technical areas, I want to quickly note that in some ways you'll see we're being very precise in our requirements, including specific metrics and milestones that teams should meet to continue to progress through the program. But if you've read the solicitation, then you know that we've also left the door pretty wide open for how to achieve the metrics. We know that you're the experts, so we really want to see the creative solutions from the ecosystem on how we can achieve and in some cases even surpass the goals that we've set forth. Okay, this is a closer look at TA1, which is dedicated to building the largest normalized and curated data set of longitudinal rare disease patient data that's designed to drive the development of diagnostic models. And TA1 is focused on aggregating rare disease data at both the volume and the depth that's needed to train machine learning algorithms, as well as the breadth to provide coverage for a majority of all rare disease patients. And again, RAPID will start by targeting more prevalent rare diseases, but also expand to include ultra-rare conditions and really pushing the state of the art in handling issues of data scarcity and model development. So we'll move into more of the long tail of the disease distribution curve you can see here as we collect data for the ultra-rare conditions as well. And note that the performers in this TA will also be responsible for developing the tools or approaches for scalable annotation of the patient health data. And also, it's important to ensure that the necessary data use agreements are in place, as that'll be critical for enabling broad access to the data, which is a key requirement outlined in the solicitation. This table depicts the target metrics for both disease count and minimum sample size that's required at the conclusion of each year. And so by the program's end, TA1 will have aggregated data from over 2,700 rare diseases with a minimum of 80,000 true positive cases and a minimum of 800,000 non-rare disease patient cases that can serve as true negatives as part of the control data. And there's also a requirement for including international sources. Rare disease is, of course, a global problem, and because of low prevalence rates and wide distribution, requires a global effort to collect the data in sufficient volume and fill existing gaps. And then the milestones you can see in the second table really focus on when the data must be collected in order to drive forward benchmarking and model development in phase 2. And this is a non-exhaustive list of the data types that RAPID aims to aggregate, spanning clinical, laboratory, genomic, phenotypic, and administrative data. Longitudinal EHR data will be foundational, but we are interested in supplementary data, omics, imaging, biomarkers that can enhance patient profiling. And so the goal is to build comprehensive AI-ready patient profiles, capturing diverse data points to really simulate patient journeys using real-world data for both the training and the validation of models. Moving to TA2, so the goal here is to develop highly scalable digital systems to collect novel multimodal data directly from patients, with a focus on emerging diagnostic indicators, things like facial morphology, acoustic, voice data, and movement data. And all this data will then be used to enrich the TA1 data set and support the development of novel sensing capabilities, especially for the direct-to-patient systems that are part of TA4, and that can screen for rare disease in underserved populations who may not be well represented in EHRs currently, or who don't have access to rare disease specialists. And more details on the requirements of this TA are contained in the solicitation, so definitely encourage everyone to make sure and refer to the ISO, the solicitation. And the key metrics for TA2 include the collection of novel multimodal data from a minimum of 30,000 patients. And there's also additional requirements for demographic and regional diversity to ensure broad representation. Similar to TA1, the milestones here are intended to ensure that the data is collected on a time frame that's aligned with the benchmarking and model development. And again, we're focused on achieving the overall goals of TA2, so we've avoided being overly prescriptive on how to achieve the targets, and we're really eager to hear ideas from the community on ways to achieve these in the proposals. Moving to TA3, the performers here will integrate the data to ensure that it's usable and optimized for machine learning. The performer will process and normalize the data from TAs 1 and 2 to construct the rare disease data commons and benchmark data sets that are optimized for the training and validation of models in preparation for the clinical deployment. And crucially, we've included requirements for TA3 to be established as an enduring resource to catalyze continued rare disease innovation beyond the life of the RAPID program. So we're going to be looking for a clear plan for how this resource will continue to operate and expand after ARPA-H funding ends. We really want to see how this can become a sustainable resource. And this slide provides a more detailed breakdown of the minimum platform functions that are needed under TA3, including data integration, cleaning, normalization, de-identification, and also the hosting of the data sets that will be used for benchmarking. And once again, these are also identified in the solicitation under the TA3 requirements. Key metrics for TA3 include data harmonization, the percent of records that will be available for model evaluation, as well as the usability of the platform itself. And the high-level milestones listed here are also intended to drive development and to really keep things on track to ensure that the resources and the data are in place in time for the benchmarking competition and launch of phase 2. And so once the baseline data and infrastructure have been established, we'll launch an open benchmarking competition to evaluate different approaches to rare disease diagnostic modeling. So for the first time, there'll be a way to directly assess and compare diagnostic models across a wide number of rare diseases and empirically determine what are the most performant approaches. So we'll provide the data, the assessment tools, and the infrastructure at a scale that's really never been available before for rare diseases. And participants who demonstrate the best performance on the benchmarking will be encouraged to submit proposals for continued development and deployment as TA4 performers in phase 2 of the program. And this is a preview of TA4. So once again, before phase 2, we'll release a second solicitation that's specific to selecting the TA4 performers. And the goal of TA4 is to deploy the most performant diagnostic models for real-world validation, which will include support for integration into EHRs, clinician workflows, and direct-to-patient solutions. And performers here will work across 2 tracks. Track 1 is focused on tools that operate within the health system, including decision support systems for use by PCPs to guide clinical decision making, also tools that can scan EHRs for suspected rare disease and flag individuals for clinician review. And track 2 will develop direct-to-patient platforms, and that'll require performers to combine targeted analytics with AI-based screening tools to identify suspected rare disease patients among hard-to-reach populations and then integrate them back into the healthcare system for clinician review and support services, including things like confirmatory testing and, when appropriate, genetic counseling. And so together, these tracks will really allow us to take multiple shots on goal at different points along the diagnostic odyssey to essentially find those highly valuable rare disease needles that are currently buried within the haystacks of health data. And the metrics for TA4 will be specified in the forthcoming solicitation, but they will be similar to those that are used in the benchmarking competition, and also include additional targets related to system integration and usability. Like the other TAs, all the metrics will grow more challenging as the program advances, including for TA4. And the performer models will be evaluated both pre and post deployment. And the participants will also be provided a budget to conduct confirmatory testing to enable prospective validation to help determine the real-world precision and effectiveness of the models that are developed and deployed. And note that there will be a down select midway through phase 2 for TA4 performers that's based on the evaluation metrics. And it's expected that not all performers will necessarily reach the end of the program. But again, more details and requirements will be provided in the phase 2 solicitation that's coming in 2026. And so a key goal of all RAPID programs is to transition solutions. And in RAPID, that means first moving diagnostic models from prototypes to large-scale testing across diverse real-world settings. So models will not only have to be clinically accurate across a wide number of rare diseases, they'll also have to be resilient and effective on a variety of patient demographics, healthcare workflows, and settings that might include large health systems, but also rural hospitals, mobile clinics, or in the case of track 2 performers, home environments. And over the next year, we'll be developing a network of deployment partners. So if you're interested in piloting these solutions, please do reach out to the RAPID team. We'd love to hear from you. And finally, a key component of the RAPID program that we're particularly excited about is the patient experience partners who will support the technical performers throughout the RAPID program. So we'll select and fund a small number of advocacy groups and organizations that'll work with performers across a number of different activities and deliverables, like helping to increase patient engagement, building trust, generally ensuring that patient perspectives are baked into the program throughout the development of the different technical areas. A link to the application will be posted on the RAPID program page. And so ultimately, the objective is to go from the current patient journey that's costly, convoluted, and can last for decades to one that can accurately diagnose rare disease patients at scale and in a fraction of the time it takes today, leveraging AI to enhance clinical decision-making and efficiently connect patients to appropriate confirmatory tests and follow-on support. And achieving this has the potential for tremendous impact. It could save billions in medical costs and, more importantly, save and improve lives, with the greatest impact likely to be on some of the populations least equipped to face the already immense challenge of living with a rare disease, populations like rural, uninsured, and low-income communities. And by identifying more patients, the RAPID program can also help establish a more accurate understanding of disease prevalence. It can inform policy discussions and also catalyze interest in new therapeutic development. All right, this is an overview of the RAPID program timeline from launch to kickoff, with key milestones for technical area proposers highlighted. And first, the deadline for abstracts, or what we call solution summaries, is around 4 weeks after program launch. So be sure to check the Rapid Program page and sam.gov for current deadlines. And these summaries are only 3 pages, but we do encourage proposers to maximize that space, as this is really your opportunity to convince reviewers that a full proposal is warranted. Then in mid-March, we'll provide brief feedback on each solution summary, along with invitations to those who are selected for full proposals. And if you are not encouraged to submit a full proposal, we ask that you please do not send one in anyway. And the full proposals will then be due around mid-April. These are around 15 pages each, not including attachments. But as a reminder, if you apply to multiple TAs, each does require a separate proposal submission. And if you're applying to either TA1 or TA2, also note that there's a requirement for providing a justification for a minimum of 100 diseases that will be initially prioritized for data collection. And these justifications can be brief, but we want to understand why you're proposing to target these diseases as a starting point. And this attachment, as well as the other attachments, are included along with the final solicitation on sam.gov. And then in the summer, we'll notify applicants of selection and begin the contract negotiations. And we aim to have all contracts signed by the fall, so that's around 30 weeks total from today and program launch all the way through to project kickoff. And a final reminder that this slide deck will be available on the Rapid Program page at ARPA-H.gov, which you can access via the link here or using the QR code.
All right, well, thank you very much, Scott. I will be covering the next section, which goes over our PX partner overview. My name is Anna Soa, and I am on the Rapid team, and I serve as a technical CETA for the program. And I'm very excited to introduce you to what we're looking for and what we're trying to accomplish with our PX partners. So the first thing I want to cover really is what are the qualities of the PX partners that we're looking to engage. We're really looking for organizations that are very strongly connected with their patient communities, groups that really have expertise in patient advocacy, in what it means to gather data, what it means to outreach to communities, and they really have standards built in that are committed to ethical and transparent practices, that build trust, that build understanding, that really build long-term engagement for our patient communities. Because the end goal really is to foster and facilitate patient engagement, as you can see in the last point. And the opportunity that we're offering and the scope of the Patient Experience Partners Network is to make sure that these organizations and these teams really take care that our patient perspectives, patient feedback, and the lived experiences of patients are integrated throughout the technical development of the Rapid program to make sure that patient voices are inside the technology that Rapid aims to develop through the funding that we provide to the technical teams. And the opportunity is that we're looking to fund multiple patient advocacy groups to really support those goals of Rapid, to work together across both phase 1 and phase 2, as you can see at the bottom, in order to make sure that those patient perspectives are there throughout the full length of the program. At the moment, we're funding phase 1, which will last for 21 months, and we're imagining that initially the scope of the work will really be frequent meetings due to setup, really establishing processes, developing engagement strategies, and then of course there's the ongoing participation. Participation will be managed through our IV&V partners that we will talk about later, IV&V performers. And we want to make sure that there's a partnership between the PX partners and the IV&V performers that really puts in a structure of regular check-ins and quality deliverables. And then phase 2, which aims to be released around 2026, will be a 33-month program. And we will reassess between phase 1 and phase 2 to determine whether or not we want to restructure that PX partners, what the needs of phase 2 are. And so information about that will be coming later. And what are really the overview goals of our PX partners? The PX partners are really meant to be there to amplify patient voices and to make sure those voices make it into the technological development that our tech partners will be performing. We really want to make sure that the data we gather is relevant to our rare disease communities, that it's relevant to the lived experience of our communities, and that it's relevant to the diagnostic goals of our tech partners. We want to make sure that our communities are engaged. We want to make sure that those who are providing the data and those who are contributing to the development of RAPID are engaged throughout the length of RAPID. And we really want to build trust between communities because the technology is meant to serve the patient communities. And building trust is really at the core of a successful strategy that will bring the kind of data that we need in order to develop the kinds of diagnostic tools that we're looking to develop. So the PXP goals are really built around these 4 pillars of patient voices, data relevance, engagement, and trust. And these are some of the things that we imagine that PX partners to be doing and delivering. So we really want there to be a lot of awareness and outreach. We want the PX partners to also serve as a source of public-facing resources. If there's questions, if there's opportunities to provide more information that's more accessible, information that's more reflective of the broad range of communities that we want to reach, information that's tailored to in a way that patient communities can actually consume. We want all of that to go in the service of incentivizing data participation and building trust to make sure that patient voices go back into the development cycle as usability feedback, and to make sure that patient voices are involved in measuring success and what it means to really have valuable technology developed that will serve the rare disease community. We created an outline of some opportunities across the technical areas. I will discuss the phase 1 technical areas, which are technical area 1, 2, and 3. And I will also briefly cover technical area 4, which is part of phase 2. So for technical area 1, we really imagine that there's a lot of partnership and effort around data collection across a variety of sources. We really want to ensure comprehensive coverage. We want to make sure that there's inclusion of patient-reported outcomes that matter to patient communities. We want to make sure that the data we're collecting is the relevant kind of data, that there's ethical frameworks developed for data usage, and that there's education and engagement with the patient communities, that there's mutual benefit for both the communities as well as the technical performers. In technical area 2, we really think about gathering different kinds of data and engaging a variety of broad communities. We really want to think about that user feedback in terms of how we can get an understanding of use and contribution of data through various modalities, whether it's unique ways of contributing data, whether it's through digital technology or wearables, or really unique ways of gathering different kinds of data from rare disease communities. And we really want to facilitate feedback across all of these technical areas on what does it mean to have patients contribute data into a framework that includes AI technology, around rare disease detection and diagnosis. We really want patient communities to feel in control of how their data is being used, how technology is being developed, and how that technology is really meant to serve them. And for technical area 3, we really want to make sure that we have patients participating in the testing and feedback and the usability of platform and diagnostic tools. These diagnostic tools eventually are meant to go out to a broad range of users and not just in the clinical setting or the physician setting. And so we want to make sure that we're building tools that can be used by a variety of users. We also want to think about data governance frameworks that will really serve our communities long term, and to advocate for future functionality and patient perspectives into benchmarking and AI technology development. And in phase 2, as I mentioned, technical area 4 is really meant to focus on deployment of real world implementations of this diagnostic technology. And so what we're going to be looking forward to in phase 2 are really partnerships that are meant to turbocharge RAPID into the clinical space, into the implementation space, to make sure that we really gather that patient feedback, that continuous improvement of those tools that are really centered around education, training, involvement, that when Rapid really goes into the clinical setting, into the patient-facing setting, it really is there to serve the needs of our rare disease communities, and that the technology is developed in such a way that it delivers on the promise that patient communities have been waiting for. As we started thinking about the development of Rapid and the participation of PX partners in this melding of technology and patient voices together, we thought about personally 10 potential challenge areas that we imagine teams will be facing. These are not prescriptive challenge areas. These are things that the Rapid team has thought about. And so we invite you to either expand or contract or work on these challenges yourself. But these are a few things that the Rapid team wanted to share with you that we think are important when it comes to PX partners and their work with technical performers. I'm only going to be covering 3 of these challenges for the sake of time, but feel free to look through the slides to read the other opportunities that we have chosen to highlight. The first thing that we really think about is that broad reach. Of course, data representation is a well-known challenge in data aggregation initiatives across many agencies, government, as well as private partnerships. And so we really want our PX partners to think about creative, inclusive ways to reach out to different communities, whether it's through community ambassador programs, whether it's informal sessions in various languages, in unique formats, whether it's materials that are easy to consume about data consent, if it's videos or infographics that are really meant to reach a different variety of people, or any other unique ways that teams can help support the scaling of data collection efforts and create informational material on what it means to have AI participating in the diagnostics of rare disease and in data collection. All those things are very, very important. Another area that I really wanted to cover is engagement and retention. To keep patients and communities engaged over the long-term development of Rapid, from beginning of data collection all the way through clinical implementation, which will be in phase 2, is really important to the team and, of course, to the success of Rapid as well as the technology. And of course, the impact of not focusing on this is that high attrition rates can really compromise the integrity and continuity of any technical efforts. And so we want our PX partners to really think about opportunities for engagement and retention over the long term. How can we really support patient participation? How can we communicate benefits to patients? How can we make sure that we acknowledge participation and that we answer patient concerns and inquiries and keep organizations involved throughout the long-term development of Rapid? That's very important to us. Another thing that I wanted to touch on is accessibility. Of course, as we know, rare disease communities face a number of challenges. And when we think about data collection efforts or participation efforts or user testing or user any kind of surveys or workshops, we really want our PX partners to think about accessibility. And how do we make sure that the opportunities, whether they're for data collection, whether it's recordings, whether it's webinars, whatever it is, are really available to people with a wide variety of opportunities and capabilities. Those perhaps with limited internet opportunities or who speak in different languages, because we really want to make sure that we cover a broad range of the population that's really representative of America and representative of the rare disease community. We've just created 3 thoughts that we had in terms of creating internet hotspots or developing relationships or really disseminating materials to those with different challenges to make sure that information is really shared. And that really goes back to that long-term engagement and long-term community building piece that we were talking about. And so if you want to look at some of the other opportunities we've highlighted, feel free to go through the slides and look at the other ones as they're posted on the Rapid program page. Now I wanted to cover really the application overview. So we wanted to make sure that we made the Rapid application process as simple and as informative as possible. If you go on the Rapid program page at ARPA-H.gov, you will see a PX partner application that should be submitted and then will be given to our IVNV partners, which I will IVNV performers that I will explain in a little bit. And those IVNV performers will then issue an RFP following their review of the PXP partner applications. Those applications cover a number of topics that are really important to us to think about in terms of the scope and the scale of the organization and their reach and their ability to really talk to different patient communities. And after the RFP is issued, then our IVMV partner will make the PX partner selection. So if you are interested in being a PX partner during phase 1 of RAPID, please go to our RAPID program page at ARPA-H.gov and fill out that PX partner application. And I know that Scott will also cover a few questions and answers related to this later in the presentation. So if you have questions, feel free to submit those to us. And I also wanted to quickly cover what is our IVNV performer and what is their role. So IVNV stands for Independent Verification and Validation. And they are really a performer who works with the ARPA-H team, who will work with the RAPID team in order to meld the perspective of the technical performers and the perspective of our PX partners and their patient outreach. So as you can see in the Venn diagram, they really sit between the technical performers and the PX partners. And their goal is to really make sure that there's communication that is ongoing, that there's meetings that are set up. They're there to manage deliverables. They're there to make sure that technical requirements are translated into actionable tasks for the PX partners, and to really make sure that they're there to manage the organization of the selection process, meetings, and deliverables. So they're going to be a very close participant in RAPID and will work very closely with the PX partners. And I also wanted to end on an opportunity for anyone on this call to participate with RAPID, even outside of applying to be a PX partner. So as the RAPID team, we really believe in engaging the community in all the ways that are possible for us. And we just want to let you know that any information that you have related to the patient experience, to the diagnostic experience, if there's already reports that you have collected or surveys you have done, if you're able to share those with us so that we can reuse that material, we would really appreciate it. And we know that it would make a meaningful contribution to the information that we have and the information we provide to our technical developers as they start thinking about these diagnostic tools. ARPA-H also has an opportunity to join an ARPA-H Spoken Hub Innovation Network, which they call ARPA-Net-H. And if you go to ARPA-H.gov and then engage and connect and then ARPA-Net-H, you will see the opportunity to register and become a part of this broad network that's really meant to improve health outcomes across a wide range of ARPA-H programs. So you are always welcome to join that. That is independent of RAPID, but is definitely part of the greater ARPA-H network in a really meaningful way to contribute to health outcomes. And as well, we really want our potential PX partners to think about becoming a technical performer in TA4 or becoming a part of a technical performance team for TA4. TA4 phase 2 is slated to be released in 2026. And if you're interested, just keep a lookout on our RAPID program and look out for future upcoming ISO and special notice as it relates to phase 2. And that is all I have today. And Scott, over to you for our FAQs.
All right, I'll now cover the application process and a few of the most frequently asked questions that we've received. So first, can an organization be selected as part of a technical area proposal and also be selected as a patient experience or PX partner? The short answer is no. An organization cannot participate in both roles. You can either serve as a prime or a subcontractor on a TA proposal, or you can serve as a PX partner, but not both. But that being said, the PX partners will be selected after the TA performers have been chosen. So if your organization is not selected as part of a TA proposal, you will still be eligible for consideration as a PX partner. So if you're interested in both roles, we do encourage you to apply to both, and that'll maximize your opportunities for participation in the RAPID program. All right, this is a look at the overall application timeline. So the current estimated deadline to submit the PX partner application is the end of April. But for this and the other dates here, do check the RAPID program page at ARPA-H.gov for updates. Now, we will not provide feedback on individual applications, However, initial selection status will be communicated to everyone via email in June. And then qualified applicants will receive a request for a proposal from the IV&V performer. And the anticipated deadline for those RFP responses is July. And the exact deadlines will be included in the email notification. Then the final selections will be communicated in August. And the rapid program will kick off officially around the October timeframe with all the technical performers as well as the PX partners. But again, please check the rapid program page at ARPA-H.gov for updated guidance and specific dates as those are ready for posting. Okay, a quick look at the application itself. So there are 3 sections to the PX partner application form. The first is just gathering basic organizational information, name, phone number, website, etc. The second section is around rare disease impact. And these questions are really meant to gather information about your organization's past work and accomplishments in the rare disease ecosystem. And the third section is around collaboration and partnership. And these questions are to help determine both interest and suitability for supporting the rapid program's different technical areas. And a link to the PX partner application can be found on the rapid program page. And you can also access that here using the QR code on this slide. Okay, what amount of funding will be available for PX partners? So we're not able to disclose the exact amount of funding available or the number of organizations that'll ultimately be selected. That'll be determined through the RFP process. But we can say that we've earmarked sufficient funding to enable meaningful contributions from our PX partners throughout the duration of the RAPID program. Will PX partners be matched with a single technical area performer, or will they support multiple TA performers? So this will be determined by both the submissions received as well as the technical needs of the program. And again, the IV&V performer will play a crucial role here in aligning the expertise of PX partners with the requirements of both the technical area performers as well as the program as a whole. And as the program progresses, we do expect things to evolve, needs to change. So there should be an expectation of a certain level of flexibility from all participants who are applying. Will PX partners participate in only phase 1 or in both phases? So the current application is focused on phase 1 efforts, and we plan to select a set number of participants for this phase. And before transitioning to phase 2, we'll reassess to ensure that there's continued alignment with the program objectives. And while it's possible that no changes are made to the phase 1 PX partner cohort, it's more than likely that there will be some adjustments in order to best support the program as it moves into the deployment and validation phase. Okay, and another general question that we've received, what diseases are in scope for the RAPID program? So our focus is on rare diseases, and that's as defined by either the US or EU definitions. And within that, we're prioritizing genetic diseases, but not limiting to monogenic disease. They may be both heritable and somatic, polygenic, also rare cancers, and infectious diseases are also of interest. Really, the program's focus, though, will be on diseases with complex or prolonged diagnostic pathways, and where advanced decision support systems can meaningfully reduce the time to diagnosis. And also important to note is that while we expect PX partners to have deep experience in rare disease advocacy, there's no specific disease requirements or expertise in a particular disease necessary for selection. All right, and I'm sure we didn't answer every question just now, but we do encourage you to submit additional questions through the RAPID program page, which you can also access using the QR code here on this slide. And we'll also post answers periodically to the FAQ page so that everyone has access to that information. And you can also email us, but we do encourage everyone to first review the program solicitation on sam.gov, as well as the PX Partner application form, and then to also first check the program FAQ page for more information. All right, that concludes today's information session. Thank you for your interest in the RAPID program, as well as in the role of the patient experience partners. We look forward to reviewing your applications.